Hello, I'm Jean Porter, and I spilled coffee on my notes right before coming up here, so excuse me if I have to squint a little bit. And so I'm going to talk about the role of a primary care doctor in supporting you through aortic disease. And so I just want to start briefly with kind of what is primary care, because it's not obvious to everyone necessarily what that means. Primary care encompasses the fields of pediatrics, which is kids only, internal medicine, which is adults only, and then family medicine and med peds, which are adults and children both. And any of these people could be considered your primary care physician or provider or PCP. And throughout the talk, I may say PCP or primary doctor, primary care doctor, to describe the role that this person has in your life. And I'll just mention that prior to the 1960s, primary care in the U.S. was mostly done by GPs or general practitioners, which were doctors who had graduated medical school but didn't do a residency, which is an additional 3 years of training after medical school. And it would be less and less common in the United States to have kind of a GP as your primary care doctor. So the role of the primary care doctor can be described by the 4 C's, which are first, contact. The PCP should be the patient's first access to the healthcare system and health services. It should be comprehensive, so providing the whole continuum of services from preventative to curative and rehabilitative and palliative or end-of-life care, and should be continuous with the development of a long-term relationship leading to the mutual trust and greater satisfaction for both you as the patient and for the doctor as well, and coordinated with integration of services with all your specialists and ideally care within one organization like Allina or mHealth or health partners when possible, just to optimize communication and efficiency of providing whatever care a patient needs. So why do you need a primary care provider? So in the most broad sense, having a PCP is shown to improve health outcomes, living longer and decreased amount of diseases and overall just feeling better. Multiple studies have shown that having access to and utilizing a primary care doctor reduces the need for specialist referrals. Specialists like cardiology and vascular doctors have then less unnecessary appointments and more time for patients like you that really need them. Furthermore, patients have better outcomes if they were referred to the specialist by the primary care than a self-referral, because the referrals are likely more appropriate and the people are also more likely to be kind of optimized for whatever intervention they may need. Connection to a primary care provider also reduces the use of the emergency room. In one study of patients in North Carolina, it showed that a patient with a relationship with their doctor of at least a year or more had a 37% less, they were 37% less likely to use the emergency room. And that reduction obviously benefits people financially and then also decreases the congestion in the emergency rooms. And then at the population level, more access to PCPs decreases the burden of heart disease and stroke deaths and even cancer in kind of a greater population. People are also more likely to rate themselves as healthy if they're regularly following with a doctor. It's interesting to note that in a number of studies, sorry, I lost my place here. The use of person-focused care from a PCP rather than more disease-focused care, which tends to come from specialists, can lead to less adherence to the guidelines overall, but overall potentially better health outcomes. And that's because the PCP can help assess which guidelines are in conflict for all the different health conditions and decide how to prioritize which make the most sense for you as an individual. And that's obviously in coordination with your specialists as well, who have their eye to any specific organ. And then as a brief aside, in other countries, there's a lot more focus on primary care centers, and whereas health systems in the US tend to be organized more around hospitals and specialists. And here in the US, we tend to have a greater cost of healthcare and overall less good health metrics. And so looking towards the future, a greater emphasis on primary care and preventative care can benefit everyone and our country in general. And it wasn't until 2010 that Medicare even started fully paying for preventative services, which just kind of emphasizes that we haven't emphasized it as much in this country. So when it comes specifically to the aorta, what does the primary care doctor add to the patient's care? And I think about our role in 3 phases. So before diagnosis, during the management and monitoring phase, or kind of the waiting period as it was described to me, and then after intervention. So before diagnosis, a PCP's role in this setting is prevention of and diagnosis of aortic problems. Routine checkups with your primary care doctor every 1 to 2 years, depending on the patient's age and burden of health conditions, is a great opportunity for you and your doctor to check your blood pressure, check cholesterol, and reassess your family history. They assess if any changes to your health or your family's history should prompt screening for aortic diseases. And early detection and appropriate treatment of high blood pressure and high cholesterol can prevent the development of vascular issues later in life. And screening, it's kind of been mentioned, but is checking for a problem with a test in a person who has no symptoms. And when it comes to the aorta, we're looking for abnormal widening of the blood vessel, which is called an aneurysm, that Dr. Finola just talked about. And that puts the patient at risk for a rupture, which is bursting of the aorta, or a dissection, which is a tear in the wall of the aorta that doesn't go all the way through, but leads to compromised blood flow. Our guidelines for screening the aorta are based on risk factors like your age, your sex, your smoking history, your family history, and your PCP's job is to figure out how these guidelines apply to you. You also may elect to do more aggressive screening based on additional risk factors like blood pressure or expanded family history, and then certain genetic conditions like she talked about also warrant screening. And then most patients will not have any symptoms when an aortic aneurysm is identified. Usually issues are found with screening or commonly found incidentally when a test is done for another reason. But certainly PCPs can help identify the acute symptoms of dissection or aneurysm rupture, like severe chest or back pain that would prompt you to call 911. But also more subtle changes can be identified at your checkups, like discrepancies in blood pressure between the arms, a new heart murmur, esophagus or swallowing trouble, hoarseness of the voice, or abdominal, chest, or back pain might prompt additional imaging. And then once imaging establishes the problem, then your doctor can facilitate a prompt referral to the right specialist if needed. So in the after you're diagnosed, but before intervention, not all aortic disease needs to be immediately referred to cardiology or vascular specialists. Mild dilations of the thoracic or abdominal aorta may be monitored at scheduled intervals with your primary care doctor. And the intervals may be more frequent initially and then may space out as stability is proven. And based on an individual patient's risk factors, you may decide to go to a specialist earlier or later. And the PCP can also help assess if the disease is consistent with your known risk factors or if more evaluation is needed for an underlying issue. Based on the physical exam and your family history, they'll evaluate if there's any need for genetic evaluation or if there's a need to evaluate for masked hypertension, which is the opposite of white coat hypertension, where the blood pressure is high at home but normal in the doctor's office. Or they can assess if workup for more rare causes of aortic problems are needed, like autoimmune causes or even infection. Primary care doctor will help optimize your blood pressure, cholesterol meds, and decide if aspirin is needed or not, and help you with smoking cessation, and then exercise guidance, as was mentioned previously. And then one big issue is the stress of a new diagnosis and the stress of monitoring a health condition, not knowing if or when an intervention will be needed. And undertreated mental health conditions like anxiety and depression are recognized to be risk factors for worse prognosis in patients with vascular conditions like aortic aneurysm. One study of abdominal aortic aneurysms found a 40% increase in depression in patients with that condition compared to people without aneurysms. Managing mental health disorders with medications or therapy can improve the patient's overall well-being and improve how well patients recover from surgery. Primary care doctors will also play a pivotal role in the patient education and empowering the patients with knowledge about their condition and treatment options and the importance of lifestyle factors. They can also contribute to improved adherence to therapeutic regimens. And the PCP can also put your aortic disease in the context of your other health conditions and help decide what level of concern is warranted. Primary doctor will be coordinating with your specialists regarding adjustments to medication regimen, changes to your health status, and importantly, the timing and form of intervention. And then lastly, getting a patient ready for major surgery, making sure other conditions like diabetes or lung disease, kidney function, alcohol and cigarette use are managed to the greatest degree possible. So, once a decision has been made to pursue surgery and the patient has been medically optimized, care is transitioned to the hospital team and the surgical team. After the time spent in the hospital, the discharging team typically recommends follow-up with the primary care clinic within 1 week of leaving the hospital. And in coordination with the surgeons, the primary care doctors monitor the patient's recovery, ensuring that vital signs and wound healing and overall health are progressing as expected. Follow-up with the primary care physician reduces the risk of repeat hospitalization in the first month, and significantly, and a lack of a primary care doctor visit significantly correlates with the risk of a patient having a slower recovery or a more difficult time getting back to their baseline level of functioning at 1 year after surgery. So I wanted to talk a little bit about kind of the other things that primary care doctor can help you with after surgery. So after getting home from the hospital, there are still a lot of issues that may be ongoing or may arise, and oftentimes people don't feel like themselves. Pretty much every body system can be affected in the postoperative period and feel different than it was pre-surgery. And I'll go through a couple here. So for the brain, a decrease in cognitive function like memory or language abilities and problem solving can occur in 50 to 70% of patients in the first week after surgery. And about 20 to 40% of people will still be having difficulty at 1 year after surgery compared to how their thinking was before surgery. Risk factors for having more difficulty include older age or pre-existing cognitive trouble or pre-existing mental health disorders. And this is generally managed similarly to how it would be in other people that have trouble with memory. Which can include a reduction in medications that slow brain function, social and intellectual stimulation, and then consideration of formal neurologic testing depending on the trajectory that someone's on. And then for mental health, as I mentioned earlier, mental health issues like anxiety and depression are very common preceding and following surgery, and postoperative depression can be as high as 20% and can be managed with medications or counseling or both. From the chest standpoint, after thoracic or aortic or valve surgery, chest pain and shortness of breath can be expected to some degree. Even for months after surgery, you may not feel back to your usual abilities, and your PCP can help you sort out what's the normal recovery process versus what would warrant additional testing. For bowels and digestion, Constipation can be common after any surgery, and depending on the length of need of pain medications and the location of the surgery, additional help with stool softeners is often needed. And then on the other end, diarrhea can also be really common, related to new medications, including overdoing it with stool softeners and dietary changes, or sometimes even infection. Diarrhea can also actually be related to constipation, believe it or not, and your primary care doctor can help you sort out what steps may be the most helpful to improve things. And then kidneys and bladder, about 30% of people have some degree of kidney injury after surgery. It's usually temporary, but patients that had kidney disease before surgery may need more monitoring and may have more permanent long-term worsening. That will require careful ongoing monitoring and potentially adjustments of other medications that a patient was using prior to surgery for other health conditions. And then some patients will also have trouble with urinary retention, which is the inability to empty the bladder. That can be related to many factors, including the anesthesia, the pain medications, constipation, and pre-existing prostate or pelvic issues, as well as mobility changes. As far as reproductive organs, after major surgery, both men and women may have less sexual activity or be less satisfied with sexual activity. A variety of factors can contribute to that, including the side effects of medications and depression, as well as fears about causing a complication or even dying. And the medical team can help advise on when physical activity is safe and help optimize medications as much as possible to improve sexual function. Menstrual bleeding patterns are also disrupted by open heart surgery in the majority of premenopausal women. The change in menstrual bleeding is neither long-lasting nor usually such a large quantity as to significantly impact postoperative blood levels. However, if a woman is on new blood thinning medications, periods can be quite severe, and additional help with oral medications or an IUD may be needed. And then pregnancy considerations are a little bit out of my wheelhouse, but I wanted to mention that women of reproductive age will be counseled on the need for careful planning and coordination with their gynecologist and their cardiology specialist before pregnancy. And the last couple, so musculoskeletal, loss of strength is a big concern after surgery, especially in older people. Lower weight to begin with, or diabetes, or longer hospital stay are risk factors for more loss of strength. And the greater the degree of muscle loss, the more at risk people are for further challenges with mobility or falls or trouble kind of just doing your normal activities. And so a primary care doctor can help you navigate those risks and optimize nutrition and muscle building to help give you the best recovery possible. And then one that is maybe less serious, but people care about a lot, is skin and hair. So hair loss after surgery to varying degrees is extremely common. After any major stress, hair loss can be caused by a process called telogen effluvium, which is just the fancy doctor words for that process that happens. And then similarly, very common to have changes in the nails, especially horizontal ridges that develop and may take 3 to 6 months after kind of the stress is over to go away. And rashes from a variety of causes are also common, and your primary doctor is there to help you figure those out too. Regular checkups with your primary allow you to identify and address any postoperative complications promptly, clarify and adjust the medication regimen, and the PCP can serve as a central point of contact between you and the specialists. They're also critical for adjusting medications and treatment plans for your other health conditions, as the whole body's physiology can change after major surgery, and you may need other health conditions to be adjusted as well. And the primary care doctor helps ensure that the patient's recovery is holistic and well managed, and their role extends beyond the immediate postoperative period as well, focusing on long-term health and quality of life. And that's all I've got.